Welcome everyone to the session, and thank you for picking the DEI breakout session. I know there's some other really amazing sessions, but we're excited to have you here. And today what we're going to talk about is gender-informed care and what every pediatric surgeon should know. We have a really awesome panel. Sorry, having some slide issues. There we go. Here to discuss this issue with us, and no one on the panel has any specific disclosures to make. So what we're going to do today is we're going to take you on a journey through gender-informed care. We're going to start with laying some groundwork in terms of talking about definitions, what is sex, what is gender, how are those things experienced, how are people's identities felt and expressed, and what do we as pediatric surgeons need to know about that. Then we're going to talk a little bit about what gender-informed care is in more of a clinical sense when we're interacting with patients, and why it's really important to be educated on this and to really practice gender-affirming care and care that affirms people's identities. We're going to talk a little bit about what gender affirmation is and what that can look like, just so we can be informed when we're interacting with patients that are going through any sort of gender-affirming process. And then we're going to finalize our presentation by actually talking about the intersection between gender-diverse youth and the DSD population and what we can learn from both populations to provide better care really to all our patients. So I'm Dr. Martin. I'm a pediatric surgeon at Maria Ferrari Children's Hospital in Westchester, New York. I am the chair of the current DEI committee, and I'll be helping moderate this session with Dr. Richards, who's our vice chair. She's a pediatric surgeon at St. Luke's Children's Hospital in Boise, Idaho.
All right, thank you so much for having us. I want to introduce the rest of our speakers for today. First, we have River Graziano. They are a student at Arizona State University. We also have Dr. Cockrell. She is a pediatric surgery research fellow at Seattle Children's. She's doing her residency at the University of Mississippi, and she's the secretary of our committee, and we would not be here without her. We also have, maybe I can advance the slide, Dr. Van Leeuwen. She is the director of reproductive anomalies in the DSD clinic at Phoenix Children's and the Associate Surgeon-in-Chief at Phoenix Children's. We also have Dr. Shaw. He is a Pediatric Surgery Critical Care Fellow at Mott Children's Hospital, and he's also a resident at the University of Texas.
Hi. So today I'm going to be talking about failing upwards, the magic of messing up together, because I believe it's a lot easier to think of it as just already assuming that there are going to be mistakes. How do we handle them well, instead of how do we try to avoid them entirely? So to start off, I wanted to share a little bit about my personal journey with discovering I'm non-binary, since I feel like it can be very like a foreign concept to a lot of people. So I used to view being non-binary, like when people described it to me, as being very on the fence of gender and somebody who didn't really like either of the camps they were given. They just sort of didn't sit in either one. So when I managed to confidently fill out F on every single one of my documentations or medical forms, I thought, obviously, there's no issue. I didn't hate being a girl, so it must be fine, right? But it wasn't. I didn't really love it, and I just sort of ended up feeling weird in my own skin, like a stranger. But then I was asking myself, and I realized we don't define ourselves based on our least favorite color or our least favorite activity. We define ourselves based on what we love. So I asked myself, what do I actually love about my gender and my expression? And I didn't have a good answer. The thing I ended up learning is that gender's not meant to fill a box on a sheet. It's about being proud of the way you express, even if that's all you're doing. Finding what I loved about being non-binary changed my life. You can tell I probably look a lot more confident and happy in these pictures than some ones I started with. So I encourage you all to ask yourselves while you're learning about these identities, what do you love about your gender, about its expression and its culture, not just what do you tolerate. Asking myself that is what brought me here and to my identity, and I don't regret a single thing about it. So I think I'll be staying on the fence because the view is much better up here anyway. So to go into the bulk of things, the overview of some basic sort of labels and terms that can be confusing. Gender and sex is kind of the biggest one. There's a lot of different definitions for this. There's not really one agreed upon definition, but generally speaking, sex is referring to exclusively the physical characteristics of someone's body. And it is not deterministic of their identity or expression, although they're often linked socially. Gender, the important thing to know about that is that it is not just simply how do you express yourself physically. It can be clothing, makeup, personality, voices. There's a lot of different things that go into it. It doesn't just have to be physical. And cisgender versus transgender is just sort of like the labels that we use to differentiate those who identify the same as they were raised or assigned at birth versus somebody who is transgender, which we usually think of as like the male to female or female to male. It also applies for sure there, but we also use it more of an umbrella term, just sort of as an opposite. So when referencing biological sex specifically, which is obviously super relevant to here, referencing specific anatomy whenever possible, instead of saying like male parts or female parts, will make somebody feel more comfortable. They know already what anatomy they have. They just don't want it to be assigned to a specific gender or expression. I know I've heard in the medical field, we hear assigned sex at birth. In the queer community, you often hear assigned gender at birth. But either way, the acronyms AMAB for assigned male at birth and AFAB for assigned female at birth track and are consistent. And then just some basic of the common trans identities. Everybody's different, and even all of these can be their own spectrums, but this is just the basics. Transgender is the male to female or female to male that you typically hear about. Non-binary people tend to exist somewhere in the middle, not necessarily directly, but somewhere in between. While genderqueer or gender fluid people tend to feel differently on different days, and they want to acknowledge that in how they express, versus agender people who do not want to be a part of the spectrum at all, and often how you refer to that person is very individualized. When it comes to pronouns, that's been big, especially lately, and I know more and more forms are including pronouns as a part of them. The one thing I think is really important to remember is that we often hear preferred pronouns, which I think makes sense, but I think about it a lot like preferring not to have cheese on a hamburger versus being lactose intolerant. In neither situation is getting cheese going to kill you, but it's not really the same thing as a preference. It definitely has an effect on your body and on your health. Sometimes the idea of preference implies that it's somebody's choice that they shouldn't be taken seriously, but it very much should be taken seriously. There are some examples up here of different ways that pronouns can be introduced if asking for pronouns is something that you're getting used to or uncomfortable with. So it could be declared directly through the person's identity, usually if they're trans, or just through using it in a sentence, which is what most people do. If you see mixed pronouns, don't freak out. I promise it's not meant to be like 50-50. Nobody's measuring your usage of all of them, but they are all correct. And so if you remember, I promise that the individual in question will almost always notice and appreciate each time that switch is made. To make things more normalized, I think it would be really easy to introduce yourself and ask for pronouns when you introduce yourself. I often ask for pronouns when I'm introducing if I don't already know them, which gives me the opportunity to share mine if they haven't been asked for. But obviously, if things are forgotten, don't worry. People don't always feel comfortable listing their true pronouns, which is mostly the reason to get in the habit of this. And questions also are welcome if they lead to understanding. If you're questioning why someone did what they did, that might come across as like you don't agree with their choice or that you don't think their choice is valid, but saying that you like the way they dress and you wonder what their style is definitely not having that sort of same implication. So I said how to fail fantastically, mostly because everyone's going to fail, including the person whose pronouns they are. I misgender myself all the time, and it's super annoying because it feels like I should be the one getting this right. But the point is that you're not alone and that you should give mistakes benefit of the doubt. Correction being refused is pretty much the only point at which somebody's kind of not turning back. It'll get easier with practice, especially with collective practice. Hearing the right set of pronouns, not only from your own mouth, but from everybody else's through communication, will make things a lot easier, make the habit just a lot more ingrained in daily life. Basic do's and don'ts. Do acknowledge the mistake and restate your sentence or what you were saying before with the correct pronouns, but it truly does not have to be anything more complicated than that. If you want to apologize more deeply, I would recommend doing that privately just because it can make someone feel like their identity is a burden if they are suddenly giving people these sort of massive feelings of guilt and people are like, I just shouldn't have said anything. But don't give up and don't agonize over it. Nobody wants you to feel that you have done something terribly wrong. We're all working on it, we're all learning. And I have a couple of examples here of corrections just to sort of show how simple it has to be. This is truly entirely the process. There doesn't need to be anything complicated. You don't necessarily have to have a conversation afterwards or anything, but I just want to show how simple it can be and how it does not have to be painful. So this is a conversation between a doctor and a mother that just goes, as for your child, I'd like to see her in 2 weeks. And the mom says, they use they, them pronouns actually. Thank you for the correction. I'd like to see them in 2 weeks. So just a quick thank you, switch the sentence, and you would just move on, like it didn't happen. Same here, this is between 2 doctors. My patient has been reporting a lot of pain, but she's having a procedure soon, so hopefully that will lead to improvement. Did you mean to say he? Yes, sorry, I meant to say that he's having a procedure soon. I think this is a good example of not only a correction, but how you can correct somebody else without being rude, just assuming that they meant to say the correct thing and gently reminding them. But yeah, major takeaways from this, small language adjustments have huge impacts, and knowing how to correct mistakes in those small little language bits is way more important than just not making mistakes at all. Queer and questioning kids will notice you correcting yourself and will notice you making an effort to see them and see their true identity. And so they're gonna feel a lot more safe around you and in your hospital. You should not be working alone on this. Everybody should be working together. It's obviously going to feel like a lot if it's just you, but it shouldn't have to be. All right, thank you.
An estimated 1.6 million people ages 13 and older identify as transgender in the US. Among adolescents ages 13 to 17, 1.4% identify as transgender. Currently, 29% of trans youth ages 13 to 17 live in states that have passed bans on gender-affirming care. And an additional 21% of trans youth live in states that are considering policies that would further restrict access. These are examples of headlines from a single 24-hour news cycle. The minority stress model provides a framework to help us understand how the combination of anti-trans legislation and transphobia in the media negatively impact the health of transgender and non-binary youth. According to this model, transgender and non-binary adolescents occupies marginalized gender identities, which make them uniquely susceptible to both distal and proximal stressors. Distal stressors include gender-based discrimination and victimization, while internalized transphobia and resultant gender identity concealment are examples of proximal stressors. These have direct negative impacts on both mental and physical health. Research suggests that 83% of transgender adolescents experience depressed mood, and more than 50% meet some diagnostic criteria for depression. Rates of suicidal ideation may be as high as 55%, and a 41% lifetime prevalence of suicide attempts has been reported. For this reason, the Endocrine Society and the World Professional Association for Transgender Health, or WPATH, have recommended access to pubertal suppression with gonadotropin-releasing hormone analogs, or GnRHAs, for youth who identify as transgender or gender non-binary. Pubertal blocking therapy may allow these adolescents to explore their gender identities without the additive stress of experiencing gender incongruent physical development. Results of the US Transgender Survey found that taking GnRHAs was associated with decreased odds of lifetime suicidal ideation, even after adjusting for respondents' demographics and level of family support for their gender identity. Nevertheless, only 2.5% of respondents who reported having wanted pubertal suppression as part of their gender-affirming care were actually placed on a GnRHA. Data from the same survey also showed that 41% of respondents had never accessed gender-affirming hormone therapy, and of those, only 0.6% access gender-affirming hormones during early adolescence, defined as ages 14 to 15, and 1.7% during late adolescence, ages 16 to 17. Accessing gender-affirming hormones during adolescence compared to adulthood, however, was protective with a 30% lower odds of past-year suicidal ideation. These findings are substantiated by a study from a multidisciplinary gender clinic that provides GnRHA and gender-affirming hormones to transgender and non-binary adolescents. Baseline data from this clinic found that prevalence of moderate to severe depression was 56% and suicidal ideation was 43%. Those patients who initiated pubertal blockers or gender-affirming hormones during the study period experienced 60% lower odds of depression and 73% lower odds of suicidality compared to those who did not. WPATH recommends the following criteria be met prior to initiation of pubertal blocking therapy. They recommend that the adolescent has demonstrated a long-lasting and intense pattern of gender nonconformity or gender dysphoria, whether expressed or suppressed, that the gender dysphoria emerged or worsened with the onset of puberty, that any coexisting psychological, medical, or social problems that could interfere with treatment or that may compromise treatment adherence be addressed, and lastly, that the adolescent has given informed consent, or in cases in which they have not met the age for medical consent, that their parents or guardians have given consent for treatment and are involved in supporting the adolescents throughout the transition process. I think given the recommendations for WPATH, it's worthwhile defining both gender nonconformity and gender dysphoria. So gender nonconformity generally refers to the extent to which a person's identity, role, or expression differs from the cultural norms prescribed for people of a particular sex, whereas gender dysphoria, on the other hand, refers to the discomfort or distress that is caused by a discrepancy between a person's gender identity and that person's sex assigned at birth. Only some gender nonconforming people experience gender dysphoria at some point during their lives. Treatment, including hormones and surgery, are effective at alleviating gender dysphoria and are medically necessary for many people. Research has shown a difference in the proportion of children and adolescents for whom gender dysphoria persists into adulthood. In follow-up studies of prepubertal children who were referred for assessment of gender dysphoria, the dysphoria persisted into adulthood for anywhere between 6 and 23% of boys and 12 to 27% of girls. In contrast, the persistence of gender dysphoria into adulthood appears to be much higher for adolescents. There's a lack of prospective data, but in one follow-up study of adolescents who were diagnosed with gender dysphoria and treated with GnRHAs, all continued with cross-gender hormone therapy. For this reason, GnRHA therapy is usually initiated after the start of puberty or after the patient has reached at least Tanner stage 2 development. And this is before development of secondary sexual characteristics that might exacerbate gender dysphoria or require surgical correction in adulthood. In summary, gender-affirming care has been widely restricted across the United States, despite being medically necessary. Access to gender-affirming care for treatment of gender dysphoria during puberty is associated with improved mental health outcomes and decreased risk of suicidality among transgender and gender non-binary adolescents.
Gender affirmation, also known as transitioning, exists on a spectrum. It has no fixed pathway, trajectory, or endpoint. This spectrum is highly individualized, as some children may choose to undergo just some or all forms of developmentally appropriate transition. There are 4 realms. Probably show them to you. There they are. There are 4 realms of affirmation: social, legal, medical, and surgical. For most children, social transitioning is commonly pursued first, as they adopt the name, pronouns, and gender expression that match their identity. This process frequently involves changes in wardrobe or hairstyles, as well as utilizing restrooms and other public facilities. Tucking, packing, and binding are other forms of social affirmation. In brief, Tucking involves displacement of testes upward into the inguinal canal using tape or tight undergarments. Packing aids in creating a masculine groin contour. Binding consists of circumferential compression of breast tissue in order to flatten the chest. Coming out to family, partners, friends, and classmates is another crucial yet challenging component of the social transition. Elements of legal affirmation include changing names and pronouns on personal documents such as birth certificates, school records, and government identifications. Consideration of medical transition prompts discussion of risks and benefits with a multidisciplinary gender affirmation team. These teams often involve pediatric endocrinologists, primary care providers, social workers, and mental health specialists, to name a few. Medical transition addresses two main pharmacologic mechanisms: puberty suppression and purposeful induction of sex characteristics. Indications for each depend on the developmental stage of the patient, as well as degree of dysphoria exacerbation. As mentioned earlier, puberty suppression is most commonly achieved through administration of gonadotropin-releasing hormone analogs, such as leuprolide or histrelin. The goals of delaying puberty are twofold. First is preventing development of permanent sex characteristics that may worsen ongoing gender dysphoria. The second is affording adolescents more time to fully explore their gender identity. Therapy with masculinizing or feminizing hormones, also known as gender-affirming hormones, is indicated for adolescents who have already undergone puberty and aim to induce desired secondary sex characteristics. This includes induction of body and facial hair growth and voice deepening, mediated by testosterone, or breast development and adipose redistribution, mediated by estrogen. It is important to note that dosing regimens are markedly different from those in adults to account for ongoing emotional and mental development occurring in adolescence. Surgical transitioning remains controversial in the pediatric population, not only due to the irreversible nature of interventions, but also the legal implications of the informed consent process. Rarely, adolescents are considered on a case-by-case basis. Most common gender-affirming procedures are categorized into top surgery, which may include breast augmentation or subcutaneous mastectomy, or bottom surgery, which can include orchiectomy, vaginoplasty, or hysterectomy. Other non-genital, non-breast procedures may include facial feminization, tracheal shaving, or hair transplantation. These therapies enhance gender congruence by definitively addressing secondary sexual characteristics. Extensive education and counseling regarding procedural implications for future fertility and reproduction are imperative in this setting. So, where do pediatric surgeons fit into healthcare for gender-diverse youth? Pediatric surgeons can provide direct patient care related to transgender health by inserting, replacing, or removing histrelin implants. More commonly, however, surgeons may encounter gender-diverse youth when delivering general surgical care related to pediatric injury and disease. This includes treating children involved in trauma or diagnosed with appendicitis, hernias, cancers, and more. Most importantly, perhaps, surgeons can be allies by prioritizing safety, security, and support for patients and their families. So, pediatric surgeons will encounter gender-diverse youth in their practice, even though their role in providing direct gender-affirming care may be limited. Being an ally in all settings and aligning care towards understanding and appreciating the gender experience of these patients is invaluable.
I think that last slide was probably the most important slide that you guys could see, and I know that the moderators will kind of highlight that again, but just understand that we think the pediatric surgery community, we need to be allies for these kids wherever you encounter them at your hospital. and you will. And you already have encountered kids with intersex traits, which is why we're going to just kind of overview them really quickly and say, what can we learn from what has happened to kids with intersex traits over the last several decades? I've been in this work for 2 decades at least since my training. You would think the program chair would know how to do this. Okay, we got that one. All right, here we go for real. So kids with intersex traits, I know that's a word that we didn't used to use, but we do again now. It was kind of adopted by the advocacy communities as something we shouldn't use, but again, it makes sense to the public, and now it's back. There's different categories of DSD. How we talk to the patients in an age-appropriate way is something that we have learned through our care for DSD. And kids with DSD do get surgery, unlike kids with transgender who often don't. The DSD kids, we're relieving obstructions. Especially when they're going through puberty, if they have obstruction to menses, they are getting reconstructive surgeries. There's issues regarding consent on these patients. Can the parents make decisions for their child who's a newborn? Can they make decisions for their child who are in like an adolescent age? Or when should we really be thinking about making sure that the patient themselves is in charge? So we did talk a little bit about this new category, DSD, which is not new. It was decided on by a consensus organization in 2005, 2006. There's a lot of other terms, so just be flexible. There's a wide range of conditions. In general, the categories of DSD or people with intersex disorders are put it into 2 categories, newborns or teenagers. So these are what you guys will see in the NICU, and this is what you'll see when patients undergo puberty and maybe they don't get their period, and now you're being referred a patient who has MRKH or androgen insensitivity. For anybody who's going to take the board someday, this is a very helpful category, newborns and adolescents. Just be aware, no spoilers. And so what might be considered intersex would be these patients in the NICU who used to be, called ambiguous genitalia. It's still okay to use that phrase, but the intersex is interchangeable with ambiguous genitalia. So kids with congenital adrenal hyperplasia, kids with mixed gonadal dysgenesis, much more rare, partial androgen insensitivity syndrome, or even severe perineal hypospadias are all patients who might be considered intersex. So how do we educate families about gender and sexual health? So again, it starts with the parents and the cultural context. No one is saying that every culture and every location in this country is the same. So you really need to kind of start with, who am I talking to? What is their context? Because it's just not fair to apply one size fits all to this. Then we provide psychosocial care. There can be a formal evaluation of every family about what are your stressors, what is your knowledge of the condition, how are you as far as coping and resiliency. These are skills that can be taught in pretty much every diagnosis, right? The first discussions are at the teachable moments. So in your house, when you're talking to other family members about your child, when you're potty training, these things come up. Bath time, what kind of swimwear do we choose? What kind of books are we reading? What kind of clothing is the child choosing? You can give all these tools to the parents. This is an ongoing discussion in their household about how to raise their intersex child in a way that when they ask questions, let's just sit down at the table and let's just talk about it. In middle school, there's an interesting class that happens at a variety of ages that's called Human Growth and Development, where I'm from. I used to love this class. My kids would come home, have a lot of questions because no one at the school was answering the questions. They would say, go ask your parents. And if your parent is me, who's running a DSD clinic, I'm ready to answer those questions. So everybody knew all the words, and it was really kind of fun for me to answer these questions, but I think this is a great opportunity to teach families. This is going to come up in your house, so let me help you with the words that you can use to make your child feel like they're normal. Just because they're not exactly what the gym teacher is teaching us about what happens to boys during puberty or girls during puberty, we can say, no, you're actually special. You're like a superhero because you're better than all, you have some interesting parts that no one else has. So that's, I think, a great time to discuss it. When you go into sports, there's a lot of issues with eligibility, discussions with coaches, kids with cloaca and who have multiple stomas, and they're trying to be in sports, play basketball. Have a discussion with the coach. They need to take off and go to the bathroom, they take off. So these are the types of things that just make people feel like they're normal, they fit in, they don't have to feel so out of place. Dating is troublesome for kids with intersex disorders because they feel like they're going to get shamed. There's a lot of trauma for these first experiences, these first sexual experiences. And so we need to tell them about that ahead of time. Pick the right partners. We need to do an assessment of their own knowledge of their function and their anatomy to make sure that we're not just assuming that everything works the way that we think it should. And then moving into adulthood and making the decisions without the parents, there's a major shift. When all of a sudden a kid starts driving to your clinic by themselves, they always have a lot of interesting questions that never came up in that whole other time that you knew them. And that's the time to take a deep breath, answer their questions, and really let them talk. And sometimes my scribes, I'll either kick them out or I'll let them stay if they can keep a straight face, because some of the phrases that are being used are not phrases that you necessarily used in your house, and you need to be prepared for that. It's always an adventure and a learning experience for me, even to this day. What kind of surgical reconstructions are done in kids with intersex? So it depends. If there is an obstruction, doing something within the first couple of years of life is acceptable. There's definitely a huge shift towards adolescent and young adults making the decisions for themselves about surgery on the clitoris, surgery for the vagina, etc. And so the indications are really more obstructions. But these are just a list of some of the things that we end up doing. Nothing's an emergency. I just want everybody to know that. There's never an emergency. There's always time to make sure that a child knows fully what the implications are for any kind of surgical reconstruction. How do we handle consent and assent? This is an ongoing topic that we're very interested in. But just when we surveyed you guys last year, everyone's really aware of this. And obviously, pediatric surgeons who do reconstructive surgery, we can be at the forefront of making sure that that child understands what we're going to do and that they're ready. A readiness assessment is common in kids with transgender. And so how do we tell? Well, we can have checklists that make sure that the patient fully understands their diagnosis and is kind of walking through almost homework on this. And then just letting them know that things have changed and that there's no emergency. We have them perform what's called a SURE test. This is a 4-question test to make sure that they understand what types of procedures that we're talking about, what are the complications, have you had enough information, do you have advocates in your house or friends that are helping you with this discussion. If you answer no to any of these questions, we just pause until you're fully sure that you're ready for any kind of reconstruction. Our outcomes after we instituted this are completely different. It's way easier. So people would kind of fake their way into getting a reconstructive surgery, and we were fooled, and now when we make sure they're sure, their outcomes are much better. They're much happier. So our takeaways from what we've learned with intersex kids is that all care is customized. There's no one diagnosis that has one solution for anyone. Families have to take a lot of time to process and sometimes even grieve. If you have a patient who's a teenager, just found out they have MRKH and they don't have a uterus, it takes a couple of years for that family and that child to kind of get over the idea that they don't have that uterus before we do anything. And again, we may not have to do any surgery. An important part of care is meeting other patients and families. We almost force the peer support. And I think it really changes everything to meet another patient that has a rare diagnosis like you do and makes you feel less lonely. We divert focus to what brings joy. I don't want to talk about your genitals in the office as much as I want to talk about what you're going to study in college. What's your favorite sport? Do you like to watch the Phoenix Suns, who are playing tonight, by the way? Hopefully we'll win that game. But be the type of the caregiver that allows that comfort, flexibility. It's a safe space in your clinic. You really just don't want to be talking about their bottom all the time. And that's it for me. Turn back to the moderators. Thank you.
All right, so I want to thank our panel for their discussion and the information they provided. We're just going to review some of the things that were said, just to kind of reinforce the take-home points, and then we'll have some time for discussion. So what we want everyone to leave this room remembering is that gender diverse youth and intersex youth deserve access to comprehensive care from informed gender sensitive physicians. And we as pediatric surgeons have a responsibility to learn about these patients and to understand and know what their needs are and how to provide safe environments for them. We should understand that the poor mental health outcomes in the gender diverse population are tied often to a lack of access to care. And being able to help patients access care can help really improve their long-term survival. Like, we're talking about suicide, we're talking about survival here. The process of transitioning is multifaceted, often nonlinear, and very diverse and different for every patient. And we need to understand that, listen to what the patient's wants are, what their needs are, and try and help them as much as we can, because it's not a one-size-fits-all path. And as pediatric surgeons and non-surgeon providers, we need to support gender diverse youth and affirm them at all times. Dr. Brandt yesterday said that we need to learn and tell stories, and I think amongst ourselves it's important to continue to learn, tell stories as we meet patients, listen to patient stories as they talk to us so that we can really understand them and provide the best care we can.
Okay, so what can you do to improve your clinic and make it a more gender-affirming clinic? One, look at your space. What is your clinic like? Make sure that the intake forms are inclusive and allow for patients to use appropriate pronouns and to express themselves in a comfortable way. Make sure that there are posters, educational materials, that those include all types of patients. Make sure that your staff is trained to ask for pronouns, and make sure to feel empowered to correct people, as we talked about earlier. If a mistake is made, that's okay, but feel strong enough to correct someone and make sure that those mistakes don't go kind of unnoticed. And it's okay to pull a team member aside and privately discuss with them if they are struggling with an issue related to gender diversity. And think about your approach. Make sure that during exams you're flexible. One thing we've talked a lot about is, does every trauma patient need to be exposed completely every time? If a patient has an isolated extremity fracture, do you need to cut off all of their expensive, motorcycle gear? Maybe not. So in the same way, you probably don't need to remove a chest binding if it's an isolated extremity injury to protect the privacy of that patient. You can, it's also important if a child is having, questioning their identity or having thoughts about that, but their parents are not accepting, it's important to be private with that patient and allow them space until those parents are ready to accept, since sometimes the patient's safety can be at risk. And then, as we discussed earlier, acknowledge mistakes, apologize quickly, and then move on so that it doesn't become a prolonged apology that can bring more attention to the mistake than necessary. And then, ultimately, just make your environment as friendly and acceptable and flexible and a learning environment with respect to these issues. This is an evolving field, this is changing, and the more we learn, the more we accept others, the more comfortable and the safer it is for our patients. So at this point, we'd like to open the discussion up to questions from the audience, and thank you so much for attending our session.
Hi, Doug Miniotti from Roseville, California. So I live in we live in a politicized world, unfortunately, and I would live in what I would call a red part of California. And as such, my kids have friends who have received gender-affirming care. I work for an organization that's very gender-affirming. Yet at parties, I hear people in my community, adults, who like to point out a very high-profile case of an adult who had gender-affirming care and later had regrets, who refer to gender-affirming care as a cash business that physicians are taking advantage of. my question is, when I hear comments like that, I just remain silent typically because I don't know exactly how to respond. My own sort of personal mantra is be who you are, and I try to promote that. But how do we respond to individuals like that in a way that promotes more meaningful understanding of these issues that are hard for us to grapple with? I know that might not be an easy answer, but I'm happy to hear the comments from the group.
Yeah, that's a really good question, and it's hard when that happens. I had it recently happen to me in the middle of a OR. It actually came up, but the scrub nurse said something that I found that would be perceived as very offensive to the gender diverse community, and I thought, this is an opportunity to educate everyone in the room. So we actually, instead of talking about what we were doing on the weekend, all of a sudden we were talking about, why gender affirming care is important. And what I typically do in that setting, at least, is try and bring out a lot of what we talked about here. So we talk about what gender dysphoria is and how it's really driven by stigma and external factors, and how suicide risks are very, very high. And as human beings, we should be able to accept people, like you said, as who they are, and let them be who they are, and that there is literature that supports the fact that doing that actually saves children's lives. So that's what I tend to do. Any feedback from the group? Kathy?
Well, there's a lot of lineups, so I think just keep going back
Okay.
and forth. And, yep.
So my name's Molly. I'm just a guest, but I had this question. How, as a patient or a physician, can you navigate either state restrictions or issues with familial support when it comes to gender-affirming care in adolescents?
I think that's a great question, and really it is state by state. I'm practicing in Idaho, and a new law was just passed, and so we're working with our legal departments and working with our gender affirming care clinic to try and understand how we can proceed and what we can and are able to do. A lot of physicians in my group are advocates and are working with our government officials trying to overturn this. So I think there are ways in which you have to navigate within the confines of your state, but being an advocate is also important.
Just to add to that, I think the importance of a multidisciplinary team that involves not only people who specialize in certain areas of affirmation or transition, but also involving kind of the medical legal department to ensure that all of your decisions and what the care you're providing aligns with not only the patient but the legal aspect of it as well. So we always talk about endocrinologists and primary care providers, but also people who know what the legislature is like are also part of that team.
Okay, we'll come back to the middle.
Hi, thank you for a wonderful session. I had a similar question along state lines. For those of us unfortunate enough to live in a very conservative state where laws have officially been passed, in that interim, I know there's a lot of advocacy to try to overturn the law, but July 2023, we can no longer provide any care in the state of Tennessee. How do we advocate and how do we try to get care for these kids? Is there an opportunity to collaborate with states or centers that are providing care, and how do we cross those state lines in locations where we cannot provide care because it's against the law?
Kathy?
So I live in one of those states too, and that being said, my hospital has come up with a way to still get the care provided on a case-by-case basis with our endocrinologist, because our legal department is extremely close to what's going on in the legislature and also has come up with a way to allow those parents to seek the care. And so I would start with your own children's hospital just to see if the legal department has a nuanced solution like that. And then as far as crossing state lines, maybe it's something this organization can think about, not just for this diagnosis, but others. Because as you know, getting things reimbursed through Medicaid in another state, especially when your own home state has said you're not allowed to have that reimbursed, is going to be really tricky. Also, people don't have the cash, to go for cash pay. So stay tuned. I think this would be a good idea for us to think about for all states that have these issues.
Thank you.
We'll come back over.
Yes, good morning. Great discussion, Dr. Hernandez from Texas and Driscoll Children's. To answer some of the comments, and I also make a few comments myself. But the fastest way to change anything, having been in politics for the last 15 years, I assure you, is politics. That is the fastest way to change anything. And politicians, elected officials, only listen to two things. Voters, that is if you vote, and if you donate. That's it, nothing else. So if you want to make a difference, look at your state's voting record, and you'll find out how low it is. And that's where your state is in the position it's in. Second of all, as a father, I can tell you, I try really hard as a parent. And there's no book to being a parent. So some of our patients, I've seen in my office anyways, they get a little upset with their parents in discussing this matter. And I find it very upsetting at the fact that children need to understand that there is no guide to be a parent. And it's a difficult topic to cover. And what would also help, because I've stuck my foot in my mouth so many times I can't even count, and it's never done intentionally, is just we have to have better communication between patients and the physicians. Because patients will come in at times and I don't know that they've changed their identity or what they wish to be called, and it's not my business to judge them either. I'm just trying to help you take care of you, but they get so offended so quickly, and I find that very difficult because I'm trying to be non-judgmental. I'm trying to help you, but at the same time, what we see, at least in Texas, what I see is, if you're not an advocate for the far left or an advocate to the far right, you're everybody's enemy, and that's a problem, because people need to understand that we are raised with beliefs, and everybody's belief system is appropriate and is correct. But you need to remember, as a panel, you need to understand your audience as well. Because my beliefs may not match yours. It doesn't make it wrong or right. They just don't, and that's all right. But we need to have open dialogue and understanding both ways, not just one way. You can't be upset at your physician or your caregivers because they don't quite understand or they didn't use the correct pronoun. They didn't do it intentionally, is what I've seen. They don't do it. They just didn't know. But at the same time, you need, as a provider, you need to be understanding, and in my opinion, not to be judgmental. People are going to do what they want with their lives, and that's fine. But we need to be there as a support system for our children and our families. That's all. Thank you.
Okay. Thank you for those comments. Anyone want to respond?
I think that might be an opportunity for River to describe because River's very, as you can tell, very, kind and open. What do you do when you get a family that's upset with you or a child that's upset with you, the doctor, for making a mistake? Is there just do what your advice?
Yeah, I think it's hard because definitely, you're going to make mistakes, and even they're going to make mistakes. So I think if somebody's getting upset with you because you are making mistakes and you're doing everything you can in terms of correcting yourself, apologizing, if you're doing everything you can, there's probably a lot of other factors going on there, because there's probably a lot of places where that patient does not get accepted in their life, and that's probably been an ongoing issue with the family. So I think it's hard to not get dragged into it,
They're
but
taking it out on you. Yeah.
Ultimately, if you're doing your best, every queer kid that I know at least, they are looking for the ability to correct, not the perfection. That's important for safety.
I think this is, not to derail the conversation away from trans issues, but I think forms really matter too, and your response to a mistake on a form matters. So when I went to a dermatology appointment once, and it said, are you single, married, divorced, or widowed? And I was none of those. I couldn't get married because I'm gay. I was not single. I did not fit. And when I asked the receptionist, what do I fill out here? She said, it doesn't matter. And I said, well, it does matter, and if it doesn't matter to you, why is it even on the form? Later, I was in a fertility clinic with my wife, and the form said, do you have any ideas as to why you can't get pregnant? And we did have some ideas as to why we couldn't get pregnant, but when I told when we laughed, my wife put a smiley face, I said yes. They were very embarrassed, and they said, we're going to change that form immediately. And since then, they have completely changed their website. Really, they made changes. So I think your response even to a mistake really matters. And again, I don't want to derail this from this topic, but as a personal experience, it matters.
Yeah, the power of the apology, right? We'll go back to the center.
Thank you. Good morning. I'm Priyanka Chugh. I'm a resident at Boston Medical Center and a research fellow at Boston Children's. And I think as part of providing gender-affirming care, we need to have a gender-diverse workforce. So do you have any thoughts on how we can support and recruit and support trainees, staff, surgeons, everything who are gender diverse?
Starts at the top. Dr. Barksdale's here. He'll agree with me, but it's your administration, the CEOs, the surgeon-in-chief. If they believe that this is important to recruit a diverse workforce, and that includes all gender diversity, then they're going to send that message to the rest of the hospital system, and that's how it happens. So go there, and then see if you can get leadership to talk about it.
Yeah, and look at your space. Like, if you want to recruit gender diverse people, do you have gender inclusive washrooms? Because if you are interviewing someone who has nowhere in your building to go to the washroom where they feel comfortable, they're probably not going to work there. So I think you need to, like, have it ingrained in your culture, ingrained in your physical space, to make an environment where people feel welcome and safe. And that's the only way that you're going to get people to come. And then I think, just as colleagues, to be supportive of our colleagues and to learn and understand everyone's perspectives.
Thank you.
Hi, Ben Padilla from Phoenix, Arizona. Thank you for addressing this important topic. I actually had some questions about the long-term physiologic effects of either gonadotropin receptor antagonists or endocrine, hormone-affirming treatment. It's a long-term effects on either fertility, cardiovascular disease, malignancy, particularly of the reproductive tract. What's known about that?
Yeah.
So overall, the numbers are not hard pressed because there's not a lot out there on it. Not a lot of people are targeting this population for study because of legislature that doesn't promote these interventions in many states. So I don't have numbers for you precisely. I think there is, obviously with hormone therapy, there are, the phrases are always moderately to low to high increased risks of cardiovascular disease versus things that we see commonly like gallstones with estrogen therapy. So in short, long-term follow-up is not appreciated in these patients just yet from our standpoint. I hope that with increasing groups like this and talking about it more, that will promote more literature in this field so that we can actually have these numbers and quantify the outcomes for patients and their families. So
GnRH analogs are not well followed in transgender and gender diverse communities, but there are quite a lot of data for precocious puberty, and has been shown to be very safe in those patients. No long-term effects. Any temporary effects are often reversed once the patient is allowed to go through puberty. And those are the medications that we are often prescribing and assisting with as pediatric surgeons. In terms of cross-gender hormone administration, it's been found to be, yes, there are slightly increased risks, but similar to the population of their affirmed gender. So similar cardiac risks of the male if they're getting testosterone, or of female if they're getting estrogen. So it is maybe increased from their sex assigned at birth, but not necessarily increased compared to the population that they then associate with.
Thanks.
I think it can be considered similar to, postmenopausal hormone therapy, which was kind of demonized. I think maybe a lot of you saw this article recently. It was demonized for a while because of the complications, and then no one was prescribing it for close to a decade until they realized that women were suffering and that the complications were so low compared to how much better you would feel if you're on hormones. So that has now shifted back. So it's kind of the similar rates of possible risks, but the benefits are so much better.
Steve Fishman, I am a surgeon-in-chief at a very progressive institution at Boston Children's in one of the most deep blue states. We just elected our first openly lesbian governor. We could do better in our place, but I'm proud as to how progressive we've begun. But our providers have been victims as well as our patients. I've had to comfort faculty members who are themselves quite diverse, but who are facing repetitive personal threats, who have explained to their middle schoolers why there's bomb-sniffing dogs in their yards, to our staff who have to repetitively evacuate to clinics because of repetitive bomb threats. I can only imagine what it's like for those of you in less progressive political environments. What advice do you have for how we can provide continued support for our providers who are so brave in advancing this care?
This has been a big topic, again, with our legal department, and my hospital was part of that group of hospitals that was targeted. But I think that going to someone like you who's supportive and understanding what are the protections we can provide to you, you do have to go underground a little bit at some point, but what protections can we provide you? We can't be on social media. It just makes it worse, so that's not helpful. That sets us back, because since intersex care cannot be talked about right now because it's confused so much with transgender care, so it's going to set us back for years of just not being able to talk about it. This venue is super helpful. The fact that this whole panel feels very comfortable talking about this here, that it was allowed, that Dr. Kandel requested that we have a gender-informed care session. So I think we find more venues like this where your staff can come and feel like, oh, at least there I can talk about this and educate people, because this is safe for us to do so. We really appreciate the attendance at this session and your attendance at this session to show that support. It goes a long way. Other strategies you guys have for care at your hospitals?
I think it is hard. I think, you know, even in Idaho, same thing. There are threats out there, and one of our, somebody took a picture of our gender-informed care clinic and posted it to some very conservative websites, and there were potential threats. You know, when it becomes your family, it does change, it is different. But at the same time, ignoring it or being silent is not going to make it go away. It's not going to get better. So balancing safety and family safety with making sure that we can keep our patients safe, it's hard. There isn't an answer, I think.
I do want to contribute from like the queer kids perspective of like going through medical processes and kind of walking into a room and assessing my safety. I think that like all of the efforts that everyone in this room is making, even just being here, but improvements made, even just little things, like I promise it is noticed and it is appreciated, because every single person that fights for us, we want to recognize and appreciate. So thank you to everybody who's going back and already sort of thinking of how can we improve, because like that's exactly, like it makes me so happy to hear it, even though I do not have my own hospital to go back to and improve.
Yeah, so I think we'll wrap it up at this point. I think we had a really good discussion. The DEI committee did produce some merchandise, swag for the meeting to help take the message back and to help signal to our patients that we are safe providers and that they're safe in our environment. It includes ABSA Pride pins. They're on a table just outside the door. You can put them on your lanyard, you can put them on your white coat, your ID badge. It's just like a visual cue when you interact with people that, you know, hopefully you're a safe person, they can be open with you. There's some equity stickers or quality stickers that you can put up in your clinics or wherever, take them home to your kids. So just, we've got lots, grab them on the table so that you can try and create those safe spaces for your patients.
There'll be lunch outside, I think starting either now or 11:30, and then we're coming back here 12:30, correct, for the next scientific session. Thanks, you guys. Have a great lunch.